Okay, good. Well, let's go ahead and get started. We've got some interesting cases. Have you guys had a chance to look at the cases?
Yep.
Good. Okay, because we post them online. We've got Path Presenter, and hopefully you'll enjoy the session today. So the way we usually do these is just kind of ask if anybody wants to volunteer and sort of discuss what they see, and kind of go through like whether you think it's inflammatory process or neoplastic process, benign or malignant based on what we see, what kind of differentiation it's exhibiting. If it's inflammatory, which of the 9 patterns of inflammatory diseases it generally tends to be recapitulating, and then which specific diagnosis. So somebody want to give this a go?
So this kind of it's like a fragmented piece of tissue, but I didn't think I saw like epidermis from what I'd seen, but it looks like it's probably dermal area, but it has kind of like this sclerotic or like collagenous appearance with like these cleft, like it almost look like vessels, but I don't think any of them are vessels. And it kind of looks like it's we see some fat there, so it seems like it's almost maybe kind of some neoplastic entity that's kind of going into the fat.
Yeah, I think that's right. I think it's probably kind of like a dermal based process, kind of a nodule. And yeah, so I think it's a neoplasm. I think your description is pretty good. Do you think it's benign or malignant just based on this?
I think it's benign. Just looking through, I don't see like atypical, like hyperchromatic atypical cells kind of sticking out in the dermis.
Yeah, that's, you know, it's unfortunately, it is kind of fragmented. We don't really have the whole thing, but it seems like it's got a fairly round edge here. And if this were kind of the whole thing, it looks fairly symmetrical in here. It's suboptimal specimen because it's kind of fragmented, like you said. And then you say, well, it's probably benign. And if it's a neoplasm, it's more likely to be probably non-epithelial, because you mentioned it had kind of a fibrotic or sclerotic collagenous stroma to it. And I agree with that. And these are fibroblasts in here that you can see, and they're not really atypical. There's really no mitoses. There's no striking atypicality or any of those kind of things that you described. Is there anything that that this area here kind of brings to mind?
It kind of reminded me of like PASH or something from like breast, but
we don't do breast and dermatopathology. So.
Yeah. It looked like it could be like vascular space. I don't see any linings or anything, but like, I don't know, some type of mimicking some vascular lesion or something. I don't know. But
yeah, if you haven't seen this, you might not know what it is. Somebody's chiming up there in the, have an idea there?
Are you talking about the collagen bundles, like the Van Gogh starry sky kind of?
Yeah, you could possibly call that starry sky, like these little things over here a little bit. Yeah, maybe so. A lot of people refer to this as kind of like grain of wood, if you will. These little clefts between the individual collagen bundles and the fibroblast here. And if you notice the collagen, there are fibroblasts here, but the collagen is kind of homogenized, and there's a decrease in fibroblast in some of these areas here. So it's got sclerosis. If you get fibrosis, you get an increase in the number of fibroblasts. If you get sclerosis, you get a decrease in the number of fibroblasts with homogenization of the collagen. So at least part of this collagen is sclerotic. There's still some fibroblasts in here, but mostly it's kind of sclerotic. So does anybody know what this diagnosis is?
Sclerotic dermatofibroma?
Yeah, no, it's actually a sclerotic fibroma, which, so dermatofibroma generally will have more fibroblast and pseudophages and histiocytes and whatnot. This usually, and you can get some thickened keloidal collagen bundles in dermatofibroma. Usually you don't get the sclerotic collagen bundles like we see here. But this is pretty good for a so-called sclerotic fibroma. Another name for this is circumscribed storiform collagenoma. That's another name that's used for it. And there's one important component of this, one important thing that this lesion is associated with. Does anybody know what that entity is?
Cowden's.
Yeah, Cowden syndrome. So it's actually patients can get GI malignancies, GU malignancies, and other things like that. Usually if they just hit one lesion, it's really not significant, but if they get multiple lesions and you biopsy these, they can actually, it can be associated with that condition. So it's something just to kind of remember or realize that it can look, this is what they look like histologically. And if you see this, if they were ever show, say on your board examination, probably too mundane to show on a pathology board examination, but if somebody decided to put it on there, just remember that it's associated with Cowden syndrome. So I would, you might just take a moment or two and bone up on what that syndrome is associated with. It's autosomal dominant, associated with, I think mostly GU and GI cancers. I think they may be breast cancer, but mostly GI and GU, as I recall exactly on that. So good. Let's move on to the next one. So this is, we've got all these really deep tissue biopsies for you surgical pathologists there. We didn't want you to feel like we were just sending these little tiny shaved biopsies that we see in our lab every day. Anybody want to give this one a go?
Yeah, I mean, this looks kind of like we have a lot of just maybe like fat or subcutaneous tissue, and there's a little bit of like fibrous infiltrate throughout and some darker, I'm not sure if those are like calcifications or.
Yeah, how about at this power?
Yes, they look more like calcifications, like bony fragments.
Yeah, good. It's calcium.
Mm-hmm.
And notice where it's kind of diffusely deposited here.
Yes.
And here, you've even got some put in these areas right here.
The vessels almost.
Yeah, that's in a blood vessel.
Mm-hmm.
And it's a small blood vessel, which is important because you can see calcification of relatively large blood vessels in patients that have atherosclerosis and whatnot. Monkenberg's calcification doesn't really mean anything. But if you get this diffuse calcification like you see here, and these small blood vessels are calcified, and that made me a small thrombosed capillary here. Let's keep scrolling around. But notice that the calcium is really involving these areas between these individual lipocytes. And there's also this degenerated fat here. And then you get these little tiny, almost kind of peppery, tiny little calcium deposits here in these lipocytes here. So anybody have any idea what this is?
Calciphylaxis.
Yeah, good. That's exactly what this is. And that's generally a pretty serious diagnosis. There are patients we now know that have calciphylaxis that can have kind of a chronic form. When we used to see it back in the day when I was training, it was almost considered kind of a medical emergency. And a lot of these patients had renal failure. They had abnormal calcium and calcium phosphate product abnormalities, and they had elevated parathyroid hormone. And a lot of these people would then get calcification of blood vessels in the internal organs, like in their heart or in their brain, and they would die of myocardial infarction, or they get GI calcification and then die of infarcts due to their bowel. So it's a pretty serious situation if you start getting calcification of a lot of blood vessels throughout the body. But there have been a few cases in the last few years of people that have renal transplants and even liver transplants and other transplants that don't really have a very acute aggressive form of the condition. They can have kind of more of a smoldering disease. So it's not always a death sentence. And it can be treated with sodium thiosulfate. Obviously, you want to make sure that they don't have an abnormal calcium and phosphorus product, and make sure that their parathyroid hormone is not strikingly elevated. But If they don't have that, then they can be treated with more conservative measures such as sodium thiosulfate. There's a good example of this. So in general, if it was just kind of dystrophic calcification of blood vessels and whatnot, you really don't get this much involvement of the fat like that. And you don't get these real small little tiny spicules of calcium, and you don't get the small blood vessels involved. You guys seen that before? I'm sure you probably have, right? Okay,
A few times.
let's give this one a go.
Does somebody want this? I guess I can try, Dr. Cockerell.
Okay.
It's circumscribed. I see some dilated blood vessels. I guess you could say slit-like blood vessels. If we go a little closer, sometimes I think it might be like alveolar, I guess in some areas. But around some of the blood vessels, there's vacuoles of fat. You could possibly think they're lipocytes, but I think they might be the endothelial cells that are having these fat vacuoles.
Yeah, I think you're right. I think some of these little vacuoles, I'm not sure if they're fat or what they are, but they're actually inside the endothelial cells. That's actually something that has been described with this entity.
So I guess on my limited knowledge, this might be a spindle cell hemangioma. We might want to exclude, I guess, is it Kaposi sarcoma? And
well, let's look at it at low power again. So you think this is it's pretty round, isn't it? And it's fairly small. I mean, this whole biopsy is probably maybe a few millimeters. So it's a pretty small papule. And it looks pretty symmetrical. If you draw a line right down the middle of it, it looks fairly symmetrical. There's really no striking atypicality of any of these cells here. And notice, you're totally correct that these are vacuolations inside these endothelial cells. And notice how prominent the endothelial cells are. They're protruding into the lumen of the individual blood vessels. And then look at the wall of these blood vessels. Notice how thick-walled this is. And then there's one other clue to the diagnosis here. What kind of cells do we have in the infiltrate? Can you see those?
Can you hear me?
There's a lot of eosinophils.
Yeah,
A lot of eosinophils. A lot of eosinophils and also some lymphocytes. It's almost forming kind of almost like a pseudolymphomatous nodular aggregation here with all these blood vessels that have these very thick walls and the really prominent endothelial cells. And some of them do have these vacuoles inside the endothelial cells. So does that change your diagnosis a little bit?
Is that trying to form a granuloma, like because of infection or something?
Well, if you're gonna, so I think it is a vascular lesion. So we're on the right track there. But what kind of inflammatory cells do you usually see, say, for example, in Kaposi sarcoma? And usually also in KS, you don't get these really thick wall blood vessels. You get these slit-like vascular spaces, and they don't really have the really prominent endothelial cells protruding in the lumen. So they're usually very more spindle cell as opposed to these almost epithelioid endothelial cells here. And if you do get inflammatory infiltrate in KS, it's usually plasma cells. So you don't usually see EOs like this. So does anybody know a diagnosis where you see a vascular proliferation with these sort of thick wall blood vessels and the prominent endothelial cells associated with abundant eosinophils? Also sometimes even with circulating eosinophilia as well.
What about polyarteritis nodosa?
Yeah, you know, that's more of a vasculitis. So you can get a small vessel vasculitis. You can kind of a larger blood vessel vasculitis in the dermis with inflammation of all the blood vessels, neutrophils, those kind of changes. But here you've got eosinophils, and it almost looks like a lymphoid process with eosinophils.
Are we talking about like Church Strauss?
Well, that's also kind of a vasculitic condition.
What about like the chimera?
Yeah, there you go. Kimura's disease, or angiolymphoid hyperplasia with eosinophilia. So angio, lymphoid, it kind of looks like a lymphoid. It is hyperplasia because it's not really even thought by everybody to be a neoplasm. A lot of people think it's actually kind of a hyperplastic reaction pattern, often related to trauma in some cases, with eosinophils. So you get a lot of eosinophils in the infiltrate of these lesions very commonly. So this is a beautiful example of this. So if you guys haven't seen this before, go back and look at this, because this is just a classic, beautiful case of this entity. And this is exactly what they look like. They get the really thick wall blood vessels, they get the prominent endothelial cells, they do get the evacuation of some of these endothelial cells as well. You get the lymphoid aggregations, and then you get all the eosinophils. So this one's got, ticks all the boxes. I mean, it's got everything here. So if you haven't seen it before, you wouldn't really know. So now that you've seen it, you may see it again someday. They come in as usually these reddish nodules, are often on the scalp. Ears a common location. They may have some kind of history of trauma, something along those lines. Now, the Kimura's disease is seen in usually in Asian individuals, and they get multiple lesions in multiple locations of their body. They the head and neck, the trunk, they get all over the body. So it's a slightly different clinical presentation, but histologically, it looks just pretty much just like this. So it's kind of a histologic identical twin, but clinically, it presents a little bit differently. So that's a really good example of that. So if you hadn't seen that before, you probably wouldn't know, but now that you've seen it, you'll probably never forget it, hopefully. Okay. A little different situation here. So we can't show you guys all tumors. You got to see at least some inflammatory diseases here. Pathologists love inflammatory dermatopathology, right?
So this looks like a punch biopsy.
Good, good.
The
Can you tell what part of the body it's from?
I know it's not from palms or soles.
Yeah.
Because it's
What's the most common place where we take biopsies if we can?
probably face or trunk.
Yeah, the trunk or the proximal extremity, something like that. We try to avoid the scalp if we can, because it bleeds. We try to avoid taking punch biopsies from the face because it leaves scars. We don't like to biopsy palms and soles if we can avoid it. So if we can, we biopsy somewhere on the trunk or the extremity. Usually the proximal extremity is better than the distal extremity. So the vast majority of punch biopsies you're going to see are taken from those locations. And not always, but the vast majority of them that you will. So I already told you it was an inflammatory process.
So there's a kind of a dense inflammation in the upper dermis, closer to dermal epidermal junction. There is almost like a lymphoid aggregates forming.
Good.
There's also vacuolization with some probably serous fluid at the dermal epidermal junction.
Yeah, this is interesting because this is probably somewhat of an artifact. Although this disease can occasionally give you some secondary epidermal changes. But the bulk of it, I think you're correct, is in the dermis. And you got this perivascular infiltrate of these lymphocytes. And then was there anything between the blood vessels down in here?
Looks, well, additional inflammation.
Yeah, notice that you've got perivascular lymphocytes, and then you've got some cells in the dermis that are a little bit more pale. And also there's some mucin in here.
Yes.
So we've got some perivascular and interstitial infiltrate. And we've got perivasculars, mostly lymphocytes, but then we've got histiocytes that are present away from the blood vessels and present in an interstitial pattern with mucin.
Mhm.
And over here, you've got some areas where the histiocytes kind of predominate. That's when we see that, we call that granulomatous inflammation, when the histiocytes predominate, at least focally. And you've got maybe even a couple of eosinophils here. So this is kind of an interesting biopsy. It's a little bit challenging, but it's a little bit unusual. But you've got perivascular lymphocytic infiltrate, histiocytes between them on collagen bundles, mucin, and then a sprinkling of lymphocytes with even occasionally eosinophil in there as well. Now that may be too challenging for you to take all that information to come up with a diagnosis, but do you have any potential differential diagnostic possibilities?
Hmm.
Do you know some diseases that can give an infiltrate of histiocytes interstitially in the dermis? If I just mention that to you, and you know, you may not know that. You guys don't get lectures on dermatopathology and things like that derm residents do, so you may not be aware of that. But if you know,
No, not
It's like
really.
like allergic contact dermatitis.
you know, usually not interstitial histiocytes with that, but things that can give you interstitial histiocytes, we think about the palisaded granulomatous dermatitis like granulonulari, necrobiosis lipoidica can do it. Scleromyxedema, you can get interstitial histiocytes and fibroblasts in that condition. Some infections sometimes can do it. And then the so-called interstitial granulomatous dermatitis associated with connective tissue diseases like rheumatoid arthritis and sometimes with lupus, so-called Wegener's granuloma. It's not really the Winkelmann granuloma, rather, not Wegener's granuloma. Give you that same sort of interstitial pattern, often with some neutrophils and some collagen degeneration in that. So this was an example, kind of an interesting, slightly unusual example of interstitial GA. GA sometimes can be precipitated by trauma in some cases. It's possible that what may have happened here, this person may have gotten an insect bite reaction and then popped up with GA at the side of the insect bite, because there are some eosinophils in here, which is kind of interesting. But you do have the abundant mucin. Mucin is associated with GA very commonly. So when we think about peripheral palisading granulomatous dermatitis, we think of if there's mucin present in the center of the palisade, you think of GA. If there's degenerated collagen, you think of necrobiosis lipoidica. If there's fibrin, you think of rheumatoid nodule. So that's this is an example of an interstitial, mostly form of GA, but it's a little bit unusual. It's got this pattern here that's a little bit of a distractor, and it's got some scattered eosinophils, which is a little bit funny. But the main thing to remember on this is just that differential diagnosis of the interstitial histiocytic palisaded granulomatous pattern, because there really aren't too many diseases that give you that. And there's one other entity that you guys should know about, being pathologists, that can simulate granulonulari, but it's actually a malignancy. There's actually 2 or 3 things, but do you guys know any ideas of things that can kind of look like interstitial histiocytes, but they're really more of a neoplastic process?
Like a sarcoma, like a epithelioid sarcoma.
Good, very good. That's the one that you guys need to always remember. Just never forget that, because it can look like GA, and sometimes even clinically, it can look like dermal papules on the, like usually the arm of a young person. Epithelioid sarcoma is one of the most common soft tissue sarcomas in young people, like in their teens, early 20s, 30s, that kind of thing. And sometimes it gets missed and gets called GA. And then, you know, the diagnosis is delayed and it results in a problem. So just remember that. There's a few other things that can look like interstitial histiocytes that are not. Metastatic carcinomas like breast cancer and those kind of things can give you an interstitial mostly pattern. Kaposi sarcoma, plaque stage KS, that can give you an interstitial mostly pattern. Neither one of those would really, I mean, metastatic breast carcinoma might give you mucin, but the KS would not give you mucin in that situation. There's a couple of things to remember in the differential diagnosis. Okay. Sorry for all these artifacts on the slide. It makes it kind of look ugly, but this is probably one that you guys see kind of routinely.
Prescribed and composed of, from here you can see many slate-like blood vessels lined by some gland spindle cells.
Yeah, so as we look at low power,
Yeah, we can see some hemorrhage too.
there's a lot of hemorrhage. Do you think this is a neoplastic process or an inflammatory process?
Yeah, I think it's a benign tumor. It's like a well circumscribed and symmetrical.
Yeah, it's actually not every single thing fits neatly into the inflammatory or neoplastic category. This may be some kind of a reactive process, possibly related to something else, but it's got a lot of hemorrhage in here. It's obviously, it looks benign. It's very, very well circumscribed. It's symmetrical and all that. And let's go to higher magnification and see if we can kind of figure out what's going on here. So what are we looking at here?
A slate-like space.
There are
around
some
the
slit-like
endothelium.
spaces in here. There's some
Yeah.
lining that are endothelial cells here too. They know they're kind of plump, not really strikingly atypical.
And also have RBC.
Lots of red
extra
cells.
precision. Yeah.
What is this stuff here, do you think?
Is that fibrin?
Yeah, I think it's fibrin. Almost certainly it's fibrin. And then you've got these blood vessels, you've got these endothelial cells, maybe even have some fibroblasts coming in here. In this area, what does this area look like?
This also looks like blood vessels.
Yeah, more like
Interconnecting.
granulation tissue here.
Yeah.
So we also got some granulation tissue, we've got some hemorrhage, we've got some fibrin, we've got some endothelial cells, some fibroblasts. So what do we think is going on here?
Is that hemangioma?
Well, it's not just a classic hemangioma, but notice the architecture, the fact that it's got this round, very round appearance. It looks like it maybe just kind of popped out of there. It's got all this fibrin and this inflammation and red cells here.
Thrombosis? Is that thrombosed?
Yes, it's a thrombosed blood vessel that's undergoing organization, recanalization, and then here it's actually formed granulation tissue reaction. So this has a specific name for it. We don't just say it's just a thrombosed blood vessel. It's actually got a name to it also. Anybody know what the name of this is? It's a pretty good name when you think about it. If you haven't heard of it, it's called intravascular papillary. See all these papillae here? Endothelial hyperplasia, or Masson's tumor. Masson's tumor, which is basically what this is just a thrombosed blood vessel that undergoes organization and forms an intravascular pyogenic granuloma here. So it's totally benign, not angiosarcoma, not Kaposi's, not anything like that. It's just basically just a manifestation of a traumatized blood vessel that gets thrombosed, recanalizes, organizes, and then it forms a pyogenic granuloma-like changes sometimes in it. You guys have probably seen this, right? I mean, this isn't just commonly seen in dermatopathology. It's probably seen pretty commonly in the kind of stuff you guys see at your gross tables and things like that there, right?
It's my
Any
first
questions
time
about
see
that? You have not seen this yet? Really?
it. Yeah, this is my first time.
Not us first years.
You will.
Dr. Cockerell, you said it's also known as Masson hemangioma.
It's called, yeah, Masson tumor,
Masson,
M-A-S-S-O-N.
okay.
And Masson was a pretty prominent French pathologist years ago, and he described several different things. There's a Masson's blue neuronevus. I think Masson's trichrome stain. So you've heard his name associated with other things. But he described this tumor also. Masson's intravascular papillary endothelial hyperplasia. It's really just basically like an intravascular blood clot that's organizing, and it often, when it forms a pyogenic granuloma, then you kind of refer to it as Masson's lesion, like here. Okay, it's a cool one here. Now, you may never have seen this before.
Oh. Well, I can try.
Okay, we like people to try. It's good.
Okay, so we from here we can see I guess centrally of this is a shave biopsy.
Good.
See some clear cells.
Good.
So, and if we go to higher magnification later, they're more clear than I guess you could say pale. You see a demarcation from I guess normal to the clear cell and the palisading cells. And going off of that, I would think between a clear cell acanthoma versus a tricholamoma. But
You're in the right category. You're in the right category. So when you say tricholimal differentiation, what are you referring to there?
There's I think throughout we saw some adnexal structures. It's similar, would you say, like to the outer root sheath?
Good. Outer root sheath. That's the synonym for tricholimal differentiation. The outer root sheath, if you look at regular hair follicles, got these very clear staining cells like this that are filled with glycogen. And so when those things, when you get neoplasms that recapitulate that, they give you this clear morphology to it. So once you get there, you say, well, there's tricholimal differentiation for sure. And they say, well, is there anything else that's more specific for this? And, you know, if you see a clear cell acanthoma, it kind of looks a little bit like this.
It's more
But if you
psoriatic.
look at the architecture, it looks like psoriasis. Yeah, it looks like very regular, elongated epidermal reedy. What's the orientation of this lesion?
It's not psoriatic,
It's kind of horizontal.
right?
You appreciate that? So it's kind of like it's a horizontally oriented lesion. It's got these little reticulated small aggregations of cells that form this kind of network-like reticulated pattern. And if you were to like to look at this, say, with a confocal microscope or something that looked at it from, you know, end on instead of en face like this, you'd probably see almost something that looked kind of like an amoeba. You know, you'd see these little tongues of epithelium kind of intercalating with one another. And then they have this tricholimal differentiation. So there's a specific entity that looks like this. This is a little bit of an unusual variant because it's got such a prominent tricholimal differentiation. But there's one other entity other than what you mentioned that can give you this sort of more plate-like, horizontally oriented follicular neoplastic process. You may not have even heard of it, but it's called the tumor of the follicular infundibulum. And basically, this one's a little unusual because they don't usually have this much tricholimal differentiation. So if you ever encounter one of these in a board examination, they wouldn't show you this one because this one's a little bit bizarre. But the idea of this is to show that's more kind of the plate-like, horizontally oriented, reticulated epithelial proliferation that's a benign adnexal neoplasm with follicular differentiation. And these don't mean anything, you know, they're not associated with any syndromes. They're just kind of a gee whiz, interesting diagnosis when you see it. You don't want to overdiagnose it as a cancer, obviously. You know, some people might look at that and say, wow, that might be squamous cell carcinoma in situ, but there's really no atypicality. The cells are really very monomorphous and homogeneous. And no mitotic figures, no atypicality. You know, it's kind of almost like it's a betweener between maybe a clear cell acanthoma, trichomoma, and then this entity. So it's kind of an interesting phenomenon. These tumors like this are thought to arise from the mantle zone of the follicle. So we always think of the follicle as being three parts: the infundibulum, the isthmus, and then the inferior portion. But there's actually a fourth portion, and that's the zone at the mantle zone, which lives in that isthmus area. And there's a lot of stem cells in there that can form sebaceous glands, they can form apocrine glands, they can form these little sort of primitive follicular structures like you see here. So these lesions are really related to the mantle zone when they form these neoplasms. So that's good. Any questions about that? Oh, let's take a look at the next one. Kind of cute.
So here we see skin where there's kind of this like well circumscribed kind of blue, hazy gray area underneath the epidermis.
Yeah.
More myxoid.
Looks 100% myxoid, doesn't it?
Yes.
So they myxoid, what do you mean specifically by that?
Like it has, or it doesn't look very cellular, I guess.
Yeah, basically just like a collection of mucin.
Yeah.
Just a little nodular collection of mucin. If you want another clue that you're dealing with something that's totally benign is if you get a collarette of epithelium around it like this, that's almost always a sign of benign. You rarely can get like metastases of lesions that go there and you get a collarette of epithelium. Usually not, because usually the collarette of epithelium, it takes a while for it to develop. It's a slowly growing kind of thing. So this probably gradually deposit over the course of time, and then you get this little collarette of epithelium over here. And then you've got some cells in here. Any idea what kind of cells we're looking at here? What's that cell right here that I'm pointing at? Yeah, it's fibroblast. Good, fibroblast. Fibroblast here, blood vessels here. What about this cell? Kind of looks like a fried egg. It's got a central nucleus with this sort of grayish granular cytoplasm around it.
Would be a mast cell.
Yeah, it's a mast cell. Good. And anytime you get lots of mucin in the skin, you almost always get mast cells in there. And you get some fibroblasts. And the mucin, the hyaluronic acid, is probably produced by this, but some of this stuff may be produced by some of these mast cell products as well. So what's the diagnosis?
I got it down to like cutaneous myxoma or like a digital mucin.
Well, or just focal cutaneous mucinosis. Probably not digital mucus, quote, cyst, end quote. That's usually seen on volar skin and whatnot. This looks like there's maybe part of a hair follicle here and sweat gland over here. So this is probably just a little focal cutaneous mucinosis or cutaneous myxoma. Usually these are just coincidental. They don't really mean anything. They're not really associated with any diseases most of the time. But there are some conditions where you can get cutaneous myxomas, like Carney's complex. You can get cutaneous melanocytic lesions like pigment epithelial melanocytomas. You can get CNS melanocytosis, and you can also get atrial myxomas. And sometimes you can even get cutaneous myxomas. You can get deposition of mucin in a lot of diseases. We saw the case of GA earlier, scleromyxedema, papillomucinosis. There you can get it. There's some connective tissue diseases, lupus, dermatomyositis. You can get abundant mucin deposits in the skin there, pretibial myxedema. So there's a lot of things that you can put in your differential diagnosis of reasons mucin ends up in the skin. If it's just a small solitary papule like this, obviously, none of those really are germane to that. But the other thing that where you can see abundant mucin is in neoplasms, like in for example, a myxoid DFSP or a myxoid neurofibroma, where you get like lots of mucin in those conditions. So there are neoplasms where you can get hyaluronic acid deposited in dramatic amounts. Now, there are two types of mucin that our body makes, right? You guys know what those two types are? You do, you're just not saying it, but you do know.
So,
There's mucin that's produced by these cells, like fibroblasts and mast cells and histiocytes and whatnot. And then there's the epithelial mucin that we see produced in places like in your salivary gland, mucus glands, those kind of glands. So they're two different kinds of mucin. They're both kind of have similar biochemical, nature to them. Sialomucin is supposedly, I think it has a lower pH, a little more acidic than hyaluronic acid, which is probably what this mucin is that we're looking at here, this mucopolysaccharide. But there are two basically types of mucin. There's the epithelial mucin produced by glandular cells that produce it and excrete it, like in your GI tract and whatnot. And then there's this type of mucin that's produced like in the skin here, for example. Any questions about that? Okay. Any takers on this one?
So this one kind of looks like it's so well we have some hyperkeratosis, some some like acanthosis. It looks like a tag or something that was like bisected. But
so you can imagine what this thing looked like clinically. So probably the person's skin was kind of down here and this thing was sticking up. And they said, well, let's just whack this off. So they just took a shave biopsy and just removed the whole thing. So probably was a little sessile or pedunculated papule. And you're right, there's a lot of acanthosis. And what about the cornified layer?
yeah, they could be like I don't know if we say it's from like acral. Well, no,
Yeah,
maybe not.
good.
No.
It is from acral skin. Excellent. So this is an acral biopsy. So this was sitting maybe probably on somebody's hand, most likely. Okay. So do you think it's an epithelial? You think it's a neoplasm or an inflammatory process?
Neoplasm.
Yeah, neoplasm. Benign or malignant?
Benign.
Good. Epithelial or non-epithelial?
I was thinking non-epithelial.
Good. Good. Non-epithelial. Any idea of what kind of non-epithelial differentiation we're looking at here?
I wasn't exactly sure, but because yeah, in kind of going through this kind of like the stock, could look like vessels or like fibrous. I couldn't really tell exactly.
Well, this is a blood vessel for sure, right?
Yes,
What about this and this?
it's like fibroblasts or spindle cells.
There's spindle. Okay, good. And now what are the three main spindle cells that we see in the skin? There's a bunch, but there's three main ones, mesenchymal spindle cells that we see in dermatology primarily. We just saw the one in the previous myxoma. Those cells in there were fibroblasts, right?
Fibroblasts, yeah.
Okay. So what's another spindle cell? That's
There's
kind of
smooth muscle cells. Smooth muscle cells.
smooth muscle. Good. And then what's the third one?
Nerve.
Nerve. Good. Now there's others, of course. You can get spindle cell endothelial cells, spindle cell, squamous cells and a spindle cell squamous cell carcinoma, melanocytes can be spindle cells. So there's a bunch, but those are the three main ones when we think about sort of the spindle cell neoplasms that we see in the skin. So of those three, which do you like here?
Smooth muscle.
It could be smooth muscle, but notice, look at these nuclei. They're kind of like
Nervish,
little.
I think nerves.
They're nerve. Yeah. Notice that you've been down that lazy river thing down at that Great Wolf Run or in San Antonio. We get that river's kind of, it's like a sinusoid, like a slow moving sine curve. Well, that's the way nerve cells tend to be. They tend to be these kind of lazy S sort of shape to them like this. So when you see that, it favors nerve. Notice there's also some mucin in here a little bit. So the perineurium and epineurium has got a little bit of mucin. So nerve lesions commonly have mucin in them, like neurofibroma, right? Those often have mucin associated with them. A type B neuruloma, schwannoma has mucin in it. So a lot of nerve lesions will have some mucin in there, give a lot or little. So that favors nerve. Okay. So let's go back. So we've got a benign neoplasm with nerve differentiation. Now, do you think this is more Schwannian or axon here? Are these things recapitulating actual little nerve twigs? It looks like it to me, right? So you've got like a proliferation of little nerve twigs in a pedunculated papule on probably a little baby's hand. They took it off like 3 months after birth. In some cases, when you see these lesions, you'll actually see some cartilage or some bone, but usually you just kind of see this. So anybody know what this is?
Perineurioma.
That usually gives you kind of whorls of fibrous tissue surrounding little small epithelioid aggregations. And it's usually see that it almost looks like a fibrous tumor. You don't usually see these nice little nerve twigs and fascicles here that are arranged a little bit haphazard array here. So they're not normal nerve twigs. Some are small. They're oriented kind of mostly vertically, but some of these up here are just kind of sitting there on their own, and they're forming these little whorls up here. So what else?
Could this be like an accessory digit or?
Yes, it's exactly what it is. It's an accessory digit. And what happens is those things get amputated, usually in utero, and the cartilage and all that kind of stuff goes away. And what you're left with at birth is this little pedunculated papule. When you biopsy it, it's basically a traumatic neuroma. And so this is a traumatic neuroma that really arose at the site of a accessory digit. This is nice Wallerian degeneration over here. So this is basically what happens in an accessory digit. It gets amputated, and then you just end up with a little papule that biopsied it shows this features of, looks like a traumatic neuroma. So good. So everybody, you'll never forget this one again either. Pretty cool. We see, those are not all that uncommon. All right, shift gears here and look at this. Now what's going on?
this looks like we have a punch biopsy. It looks like it's from the scalp, lots
Good.
of hair follicles, and some sebaceous glands. There looks like there's one hair follicle deep, but there doesn't seem to be that many. Trying to see if they're scarred or any type of inflammation around them.
Yeah, so this is, do you think this person's gonna, if you look at their scalp, what's it gonna look like?
Gonna look bare.
There ain't gonna be
look-
too many hairs in there, right? They're gonna have an alopecia here. So in deal with alopecias, what's our approach?
I guess you're trying to see if, yeah, like if they're scarred or it's inflammatory.
Yeah, is it inflammatory alopecia or not inflammatory alopecia? If it's inflammatory, is there scarring or not? You know, permanent or not? If there's scarring, is it more diffuse? Is it more just localized just where the individual follicles are? Those kind of things. Let's look over here, see if we see anything. This is unfortunately not the world's best example of this entity, but other sections showed it. It's not showing up here as well. But certainly it doesn't look like it's very inflammatory, does it? So that's going to rule out a lot of things. If we don't have any inflammation, we're probably not going to be dealing with something, let's say, like alopecia areata. We're not going to be dealing with something like folliculitis decalvans. We're not going to do lupus, like plantar. So we're going to rule out most of those entities right away. So this section doesn't show it as well as I wish it had, but there was another section that we had, and it's not in the recut, that actually showed some broken trichomalacic hair shafts. Here's one right here. See that hair shaft is sort of degenerated?
Yeah.
And then there's no hair shaft in this follicle. So does that give you any clue to the diagnosis?
So I guess if there's broken, then I would think trichotillomania.
Yeah, this one isn't the world's best example. I apologize for that because I think the original cut had a lot of this in here. Notice this follicle is kind of been ripped. Do you see how that internal root sheath is frayed here? That's not normal. That's probably where somebody twisted and pulled their hair and they pulled it out of there. And this is what was left at the site where they basically yanked their hair out of there. And this one over here is trichomalacia. There's a little bit of that left over here too. So this was trichotillomania. Now, one thing that we see in patients that have alopecia areata, and we didn't see that here, but it's not uncommon to see patients that have alopecia areata. It's pretty classic. You biopsy it and you see trichomalacia and features of trichotillomania also in there. And what happens is they start losing their hair from the AA and they go, oh my God, and they start making say my hair's falling out, and they pull it and twist it, and sure enough, they get a superimposed trichotillomania on top of the alopecia areata. So it's very common to see both frayed trichomalacic hair shafts in patients that have really classic AA. And the pattern of trichotillomania really doesn't look the same. Usually it's kind of more of a diffuse sort of moth-eaten pattern with trichotillomania. Alopecia areata, they can get like an absolute glistening white or dark skin with no hair in there at all. It's just a smooth, very smooth scalp with no hair shafts in there. So that's what we see with AA, and sometimes you get AA and trichotillomania together. Okay, last one.
I guess I can go again. So we have multiple fragments or multiple pieces here. Some of them have like more like a lobulated kind of look, but it's very like blue from low power.
Yeah, good.
And then we have these kind of has like papillary almost like architecture, but you have all these like slit-like spaces with this kind of pink mixoid stroma in the background. Yeah.
So you think it's neoplastic, right?
Yes.
And you think it's epithelial, correct?
Yes.
You like benign or malignant?
I'm thinking malignant at this point.
Well, sometimes when you get a multi-lobulated lesion like this, you kind of have to look at sort of one of them at a time. So if we just looked at this one right here, let's forget these two for the time being. If we just look at this one lesion, it almost looks like it kind of shelled out, didn't it? There's no overlying skin, so it's probably a dermal lesion. And if you look at the individual one here, it's pretty symmetrical. You can draw a line around it, it's pretty well circumscribed. You go to higher magnification, you see obviously epithelial cells, but are there any really strikingly atypical cells here?
No, not really.
No, it's not really at all. It's not mitotically active. I mean, it really looks pretty bland. So that would maybe favor benign. So benign epithelial. So what kind of differentiation is this exhibiting? It's kind of weird. I've never seen this before. So let's take a look and see if we can tell. So one thing when you're looking at epithelium, look at the lining.
Sweat gland differentiation. Is that?
Sweat gland differentiation. Now there's two types of sweat gland differentiation, right?
Yeah, it's acrine.
Well, acrine is usually comprised of small cuboidal cells with admixed clear cells. But if you look carefully, there's some of these cells that have got this snouting up here. Do you see that?
Uh,
If you look
No, it's
around, you probably find that in some other. Yeah, so it's more apocrine differentiation. Good. And there's some inflammation in here. If you look in these little areas between, in the stroma here, there are plasma cells in here, a lot of them. So any idea what the diagnosis is? It's papillated, right?
Is that syringocystadenomas papilliferum?
Well, it's close to that.
The
But that's-
hydradenomas.
Yes, this is hydradenoma papilliferum. Very close to syringocystadenoma papilliferum, only this lesion is located in the groin area, often the vulvar area of women. And it looks like a little cyst or a little eroded nodule, as opposed to syringocystadenoma papilliferum, which is more of a plaque-like lesion on the scalp that's often associated with nevus sebaceous. So this is hydradenoma papilliferum. Another benign annexal neoplasm, nice apocrine differentiation. You can really see that here very beautifully. So it's a totally benign process, just another one of the cutaneous adnexal neoplasms. You kind of look a little bit like nipple adenoma, which you guys see in the breast pathology a lot. So it's kind of a little bit similar to that, only this is located down in the groin area. And it's got this myxoid stroma with all these plasma cells in here. Okay, any questions about anything? All right, I hope you guys enjoyed the session. So thanks,
Thank
Pardeep,
you.
setting this up.
Thank you.
So we'll,
Thank you, Dr. Cockerell.
you guys will do another one sometime, you let me know.
Thank you very much. He was very good.
You're welcome.
Thank
Take
you.
care. So
Thank
long.
you.